This is one of my favorite topics, which is burns and burns management. But I feel like you guys don't really get, where is it? Okay, don't really get to learn about burns heaps, especially in Albany. So this is just simple burns management, no complicated major burns here. Okay, so the most simplest of cases. So does anyone know who this is? Or does that kind of look like something someone might have come across? So I just briefly wanted to mention this particular experiment. So basically this is Mary's room. And in 1982, Frank Jackson was this sort of psychologist, or really educational psychologist, who looked into learning and teaching. Mary is the scientist who knows basically everything there is to know about burns. Everything there is to know about color, not burns. I know burns, but everything there is to know about color. She studies color, and she's an expert in color. She knows how it's sort of perceived in the brain, how parts of the eye and which part of the eye actually interprets different colors in the back of the eye, and how that's transmitted into the brain. And then one day, but she lives in a black and white world, one day she comes across color for the first time ever, and the question he proposes is, if Mary knows everything there is to know about color, if she sees it for the first time, will she learn anything new? And I think it's really important in medicine, because we can teach you everything there is to know about everything, but until you see it for the first time, you don't really know what you're looking at. And that's what he proposes. So theoretical knowledge and actual facts don't really contribute to knowledge as much as actual context and experiment. So the next time you see a burn in ED, or a burn that's been admitted, try and see the patient and evaluate the burn for yourself. And I think that's the most important part of learning, particularly for something like wound management and care. Okay. So today, just quickly, we'll just go through simple first aid in burns, pathophysiology, what kind of questions to ask, and how to ask appropriate open-ended questions in an acute setting, and describing management options for simple burn management. This is not supposed to be didactic, like I said, so please contribute in the next few slides, okay? We're not covering major burns, no electrical burns, no inhalation injuries, no sunburns, and no fluid resuscitations. Simple burns only. Major burns are usually over 25% of body surface area, so that's what classifies as major burns. So anything under that is simple burns or minor burns, really. So just imagine yourself in ED, and it's your night 2 out of 4. You're the night doctor, and in Albany, usually it's one of us with a senior, and that senior is not a FACEM, it's usually just one of the locums, or someone who has a lot of acute ED knowledge, and comes in, 43-year-old man, flare burn, left hand, in a lot of pain, alcohol on board, now putting hand in water. Just quickly, big spiel about ED and burn management. There's a lot that we actually don't do very well in ED when it comes to acute burns. Those include overestimation of the burn and underestimation of the burn area. They also include overestimation of fluid requirement and underestimation of it. Analgesia in particular, we do quite badly. And that's the surface, really, but we do a lot more that could be improved in ED, even for minor burns as much as major burns. So to start off, before we look at the actual case, does anyone know what it means to actually have a burn? Shannon?
I guess, I don't have like just a definition that I've got from a textbook or something, but like a disruption in your skin caused by either like caused by an external source, and it could be heat, or that could be a chemical burn, or it could be something else. I don't have a great definition for it.
That's pretty good. Yep. So mainly thermal injuries, right? So heat applied to a certain area, whether that heat is through electrical transmission, whether it's through really flare burns or fire, direct contact with fire. So that's pretty good actually. So disruption of the epithelial layers mainly causing skin damage or surface damage, and then therefore perhaps even deeper damage to the area. So I hate this slide because there's so much about skin anatomy that I don't even understand. So I'll be completely upfront, but here it is. The most simplest of things that you should be wary of is, I think of skin as this epidermis and dermis. So dermis is the brain of the skin. It has the blood supply, it has the sensory supply, and then you have the top layer, which is not entirely useless, but the epidermis is the top layer that sheds mainly at the stratum corneum. So when you see older people and they have that flaky skin, that's the stratum corneum just flaking off them. Skin really makes up about 1 millimeter everywhere around the body. So it's 1 millimeter thickness, just thereabout. It functions for immunological reasons, so protecting you from infection, sweat, and so thermoregulation. It's also has endocrine purposes, so vitamin D absorption. So when you apply burn to the skin, you can think about it like an egg. Lots of proteins in the skin. If you put an egg in water, it coagulates, right? So apply heat to the skin, then it coagulates. So proteins disrupted and coagulates to the top. And have you ever come across this zone, sort of 3-layer zone of burn at all before? No? So it's as old as chips. So it's been around since 1947. So this guy, Jackson Model, it's the Jackson Model. His last name is not Model. But he came up with these 3 zones of destruction or coagulate, or 3 zones of burn that has basically never really changed in the last 50, 60 years. So the first zone of burn is the zone of coagulation. That's the maximum amount of damage applied to the skin. So imagine your curling iron, and if you've ever burnt yourself with your curling iron, and where that curling iron goes onto, and I can see Alex kind of going there. You've never used the curling iron on your hair? So if you apply a curling iron directly on your skin, that's the zone of coagulation where the direct heat is applied onto the skin. So that's the maximum amount of damage. That's tissue ischemia. That tissue is gone. Surrounding that area is this zone of stasis, which is where you have vasoconstriction, and there's reduced tissue perfusion. When you apply good first aid, that's the area you try and salvage. And then there's an area that's called zone of hyperemia, and that's the zone that's responsible for that edema after about 12 hours of burn. So that's increased tissue perfusion, vasodilation at the site, cytokine release. And then we divide burns. We used to divide them quite differently than we do now, but it's very, very simple. It's partial thickness and full thickness. If you think about it, partial thickness does not require surgical management usually. Full thickness does. So it's just as simple as that, okay? So we'll just go back to this case. So 43, flare burn, left hand, and this comes into ED. Not very nice. So if you have a quick, good look at it there. And I tell you to assess your patient. Alex? What does that mean, to assess your patient?
Probably
Sorry, you go, Alex.
cheers. Probably starting with an A to E approach
Okay.
in an ED setting. So coming in and making sure that they haven't got any burns to their just because they've burnt their hand doesn't mean they haven't also somehow managed to inhale either fumes or high temperature air, and so you're going to be checking the airway, breathing, make sure that's all fine. Going from top to toe.
So what if this was an exam setting? For exam purposes in your OSCEs, if I said assess the patient, is the key word full?
Form a history examination and do investigations.
Yes. Every time. So if you start with your ATE and you say, I've excluded the major life-threatening things that I have to deal with first, and I've cleared that, I'm going to go into a history, examination, investigation, and management. And that would be a massive tick. Okay. So can I now bring you back to real life? Not this. So real life first aid. Okay. So what would first aid for this patient look like? Ice, water temperature. In an ideal world, let's say that burn happened 0 minutes ago.
Cool but not freezing water. So
Okay.
I'm not sure the exact temperature, maybe like 10 degrees or something.
Okay. Anyone else?
And running water.
Running water? Why not bucket water?
That's just what I have been taught. But I think it would warm up the water if you have your hand in there. So running it keeps it cooler.
Okay.
I'm not sure if there are mechanisms.
Cleaner. Yeah.
Who's talking? Because I can't see you and I can't use my
Oh,
mouse.
sorry. Kate and a bit of Amy.
Oh, brilliant. Okay. Yep. Great. Anyone else?
I feel like if you do first aid courses, they sort of say like minimum of 15 minutes if you want to actually have some sort of effect.
Right.
Like doing it for a minute isn't enough to actually fix the problem. You're just making it feel better for a minute.
Okay, so 15 minutes pass. How much longer? Continue, stop. Would you go for a little longer? Would you assess for pain and then keep running it?
Really, like you obviously have to take your hand out of, or whatever body part you've burnt out of the water eventually. So I guess like once the sort of like acute kind of shock and intense pain has kind of gone away, maybe you can try like keeping the patient near the water source, but trying to take the hand out and then maybe assess for pain and really have a good look at the hand and to see how much damage has actually been done.
Okay.
But then obviously you consider like in ED, maybe getting some analgesia on board so that part is more bearable.
So, but what if you have to rely on pain to assess your patient? Do you have to rely on pain to assess depth? What's your instinct telling you?
To assess depth, sorry?
Yeah. To assess depth of the wound or the burn, do you have to rely on pain?
No.
No. So if you had no pain at all, can you say with absolute confidence that's a full thickness burn?
Not entirely sure.
Not entirely. We can. I'm going to leave that for thought, because then we're going to come back to it. Okay. So all really good answers. And ice. Did anyone say ice? Yes or no? No. I see Alex going no. Why not ice?
Might be too cold and potentially damaging to the skin.
Okay.
I think it might have some interaction with like vascular constriction, but I think maybe that'd be a good thing in the case of the burn. So.
Yeah. So that's a good word though, right there, vasoconstriction. And so ice would cause vasoconstriction and it's not good for your burn.
Okay.
So remember your zone of coagulation, that's ischemic. And then around that, your zone of stasis is tissue hypoperfusion through vasoconstriction. So you don't want to mimic that zone of stasis. So you don't want to be applying further vasoconstriction to the area. So particularly ice in major burns is quite harmful. It can deepen the burn by vasoconstriction, and it can worsen the burn. So you could have a partial thickness that becomes a full thickness because we've done that. Water, running water. Someone said running water, and that was perfect. I think it was Kate and Amy. So yes, running water. And the reason not bucket water is because you want to place your hand under running water, because that sensation of water running over the wound in itself is quite therapeutic. It's analgesic. But if you apply your hand in a bucket, you have to move it around for the same effect, and you can really damage that structure. Temperature of the water, I think, Alex, was it you who said 15, is it 15 degrees or 10 degrees?
Yeah, I said 10.
Yeah. So right about there, that research actually says about 12 to about 18. So not cool water, but room temperature water. There is a lot of data there. There's still people going cool water or warm water or room temperature, but really not scalding. So don't scald the patient and don't cool them. So right there in that room temperature water, and you can tell that by putting the other hand in. As if the other hand can tolerate that water, and that patient goes, oh yeah, that feels just about right, then you put the burnt hand under water as well. Okay. And how long? I think someone said about 15 minutes. That's perfect. So really 20 minutes is the best amount of time you could put your hand in the water. And so after 20 minutes, there's really no evidence showing that you're going to do anything that's beneficial to that burn. And 20 minutes of good running water can give you an effect up to about 3 hours of pain relief. So that's quite significant. Especially in ED, but a lot of the times people don't put their hands underwater for more than like a few minutes, so 2, 3, 4 minutes, and then they don't tolerate it and they stop. They come to ED and they're there for us to see. And you might have people coming into ED 60 minutes after the burn, and you call the burn registrar, and the burn registrar asks you if you've run the hand into water, but really you can argue there's actually no evidence for water 60 minutes after the burns happen. It's really straight away for 20 minutes, and that's about it. After that, you've really missed your window, but you could use it to apply local analgesia to the wound while you sort of gather your things. I think that answers all of these questions. And so there's some people that apply honey to the wound. There's some people that apply toothpaste to the wound. Any thoughts?
I feel like toothpaste would cause further like chemical burning.
Yep. And do you know why? I see John, and John hasn't said anything.
Sorry, I didn't hear you. Alex made a terrible joke. What was the question?
As always. Toothpaste?
Toothpaste would be terrible. It burns the skin.
Okay. It burns the skin. Do you know why it burns the skin?
Oh, I mean, it'd be something to do with the pH, I would think. If you just leave it on skin. I've woken up with bad toothpaste burns in the boarding house.
So it has sodium fluoride, and it can lock the heat in. So even Colgate don't want you getting their toothpaste and putting it on burns. And that's directly from their Colgate website. So if you have patients that tell you, I'm going to put toothpaste on it or I put honey in it, there's no evidence for any of that naturopathic remedy. No place in it in research at all. Okay. Now you'll go into history, because really you want to do good first aid. Usually a lot of that stuff in the acute setting overlaps, really. So what kind of questions did I put nope, the burn is not there. Did you want to ask this particular patient? So what do you want to know?
How long it's been since they burnt it and what they've done since?
So imagine if I was the patient. So I burnt it 60 minutes ago.
You burnt yourself 60 minutes ago?
Yeah.
Okay. And so then I'd probably flesh out how you burnt yourself. So I know it was with a flare, but was it proximity, or did you get like sticky phosphorus on your hand, or?
No, I don't think so. I was just holding onto a flare and it just went off.
Okay, and then maybe how long you think that you were in contact with it for?
Oh, I dropped it straight away. So it went off in my hand and then I just dropped it the moment it burnt me.
Okay, and then maybe ask if it got you anywhere else other than your hand.
No.
Okay, and then probably ask what you've done since. So,
what do you mean? Water? Yeah, I put my hand in ice for about 4 minutes. A bucket of ice.
Okay, silly sausage. Okay.
It's so judgmental. Huh? What was that, John?
You touched anything with the burnt hand?
Did I touch anything? I mean, after the flare? No, not really.
Are you immunocompromised?
What does that mean?
Are you taking any medications, or do you have any conditions that may make your immune system weaker?
No.
What medical conditions do you have?
Oh, great. There we go. I don't think I have anything. Patients don't answer the way we want them to answer. So how would you ask me a question like that? What specifically do you want to know about my...
Everything I had.
Maybe asking if they're on any medications.
Okay, so no, I'm not on any medications at all.
Have you ever spent a night in hospital for any reason?
No, I'm very healthy.
Do you regularly visit your GP or any other doctor for anything?
Not really. I haven't really had a need to.
Okay. So at that point, I'd probably assume that you don't have any concurrent conditions.
No, that's a good assumption. Is there anything else you want to know?
Tetanus?
Tetanus, great. No, I'm not up to date with my tetanus. Not that I don't think
We'll
so.
do that right now.
Great. Anything else? It's my left hand.
Are you allergic to anything?
No,
You're left-handed.
no, I'm right-handed.
Oh, what do you do for work?
I am an electrician. Thank you. I work with my hands a lot. Yep.
Okay. What else do I want to know? What else do you do? Like, do you have any, hobbies or things that you do that require both hands? Guitar player or pianist or something?
No, but that's a really good question. No, I'm not. It's a very, very good question. Yes.
And then maybe ask some more about the pain. So, like, how far it extends up if you've got like a lack of sensation across the bits of your hand.
Oh, no, it's just this throbbing pain in my left hand. It's a really sort of achy pain.
Are you
So,
a smoker?
yep, that's a good one. Yes, I am. I do smoke. Anything?
How much do you smoke?
About 10 a day for the last 20 years.
Maybe phosphorus. Maybe ask about stuff to do with if they're going to go into surgery. So, like with smoking, but like more like lung and heart stuff. If they've got anything. Again, if they've somehow missed mentioning it.
Yep. I like your doubt in people's history. That's exactly how I am. So don't trust anything. But good, yeah. So relevant history in burns. I think you guys have mentioned the majority of them, but here's some stuff I just want you to look at, particularly stuff that I've just colored. So the reason I've got accidentally there was this an intentional, deliberate self-harm? I think, Alex, you mentioned it, there's no other injuries, no. John, that was brilliant, not up to date with ADT. Someone mentioned dominance, that's very good. Dominance is very important, and occupation is very important because he's going to have to take time off work. What he did in the first few minutes after the burn. So he put his hand in cold water. That's really important to predict how wound healing is going, how this is going to impact wound healing for this guy. And then smoking is going to impact wound healing because anyone who smokes has high risk of infections and issues with prolonged wound healing. And then no significant past medical history, but you want to specifically ask about diabetes and peripheral vascular disease. Those are the two things. And someone said immunocompromised. You really want to ask about steroid use particularly, so because that's going to impact wound healing in this setting. Okay. Okay. So we're just going to quickly, before you look at the band, you're just going to guess the band. So you could just shout out what you think this band looks like, okay? So, partial thickness, full thickness. Who hasn't had a go? Oh, sorry, Alex, I cut you off. You can go, Alex, you can go, it's fine.
I only said full, and I probably couldn't say anything else.
Why is it full?
That pale area looks very suspicious. I don't know why.
That white area? Yep, good.
Fat. Is that fat?
No, it's the burn. It's the actual burn. So burns that are black, burns that are white, that's full thickness. Okay, that's good. This one. Oh.
Full thickness bit, right?
Yeah, why is it white, sorry?
So full thickness is white or black because it's charred. It's gone all the way down. It's infiltrated the edge. So it's really damaged the entire structure. So it's charred entirely. So it appears this way. So it's always white or it's always black. It's usually has no pain. So that makes you think of full thickness. But I'm going to contradict myself in a minute anyway. That's why I said, oh, we're going to guess the burn, but there's a trick here. So it looks like full thickness, and you're probably right around that white area. That looks like full thickness, and you could probably characterize it as such. But I want you to hold that thought, why that's full thickness and nothing else. Okay? So this one, full thickness, partial thickness.
Okay. Partial.
Partial
like
thickness.
if the blister's going to be like in the epidermis.
Mm-hmm. Who said that?
Me, Josa.
Josa, good. Okay. Partial thickness, I'd have to agree. Around it, it looks like partial thickness, right? It's reddish. It's probably quite painful. If you've ever burnt yourself, it's not very pleasant. So, yep. And this one, what does that one look like? This looks like scalded skin, but it's a scalded skin syndrome. But let's just assume this is also a burn. What is it? Partial thickness, full thickness?
This is a total guess, but would it be partial? Like, does the redness mean that it's in the dermis where all the blood vessels are?
Yes.
So it's partial.
Yep. That's exactly right. So that's partial thickness, or it appears like partial thickness burn. That's brilliant. So partial thickness burns, they're red, they're painful. Full thickness are black and they're white. And they're charred, they're yucky, they're painless. So usually that's characteristic of both kind of different types of burns. But, so looking now back to this man who came to ED. So if you had to describe the wound or describe the burn, anyone want to have a go? On the phone to somebody, and that's the burn registrar telling you, nah, don't have my mobile on me today. Don't have access to my internet. Don't have access to my email. You cannot send me photos. You have to describe the burn to me. John?
I mean, look, I won't try and describe it anatomically. I'd say
That's fine.
this man has extensive burns to his left hand, in the regions of the hand that would be used to grip, a small round object or something. So significantly on the thumb and the index finger and middle finger, mainly on the ventral side. It looks to be partial thickness.
It's in its entirety. It looks like it's partial thickness in its entirety.
Well, actually, no. So there looks like there is some full thickness, I assume, in those bits that are a bit black. But...
Okay. So what if I tell you those bits that are a bit black is just the flare, just sort of when it went off, it just had residue that kind of burned the area, and it's just applied sort of this black colored, it's not charred full thickness. It's not that charred look or that. So if I get you to look at that base of the thumb, what does that look like? Does that look just where the white is, not where the black is, where the white is? Does that look suspicious of a full thickness?
I mean, well, he directed me there, but when I'm looking at it from here, I actually feel like that's reflection of light more than it is white. But that's just me looking at it. I mean, I guess it is white. You know?
Yeah, that's okay. And then if you look at the front here, what does that look like to you?
Yeah, I can see some white portions there, definitely.
So it looks like maybe there's areas of partial thickness, areas of full thickness. Yep. That's almost exactly how I would describe it. I would say, look, there's extensive burn, particularly to the palmar aspect of the left hand. There's extensive burn, particularly to the thumb. There's areas of a mixed partial thickness and full thickness burn. I would contend that, and that's actually a blister there underneath the thumb. That's abutting the thumb just at the distal MCPJ. So then climbing around the MCPJ of the rest of the digits, so you could say something like that. It appears to be a combination of partial and full thickness burn, particularly at the base of the thumb. There's what appears to be a full thickness burn. Distally at the fingers as well, there's areas of partial thickness burn climbing there, and then I probably describe that as well there as a combination of both as well. At the dorsal aspect of the hand, middle digit at the distal end of that digit, particularly looks like a combination of both, but perhaps mainly partial thickness there. So that's how I describe it as well, the extensive burns. But here's the problem. Burns are dynamic. They're never going to be one or the other. And that's what I wanted you guys to learn. Really, out of all of this, burns are dynamic. And in the acute setting, you cannot say for sure that a partial thickness burn is only partial thickness. And you can't say for sure that a full thickness burn is only full thickness. You're never going to have someone who comes in that's painless. It's a painless burn entirely. It's just not possible. So if you look back here, that's a full thickness burn where that white area is, but then around it, that pink area, that yucky area, that's partial thickness burn. It's going to hurt. It's going to be painful. Same thing here. You cannot exclude a full thickness burn when there's a blister. You have to de-roof your blister to know what's underneath it. And around it, it's going to be painful. It's going to hurt. It's a burn. It's a bad burn. And so it's going to be characterized as both. And particularly in the acute setting, you can't say it's one or the other, because even though it appears partial thickness or there's areas of full thickness, burns are dynamic in nature. They take about 7 to 14 days to fully evolve the way they're supposed to look. So when you see them the first time, and don't feel bad, so expert burn doctors get burn classifications right 60% of the time. So 40% of the time, we're all wrong about what this burn is. Partial thickness, full thickness, it's always a combination of both. Okay, that's why it needs to be seen multiple times, not once nor twice. So if you examined this hand, I'm going to run through this quickly because I feel like we might be running out of time. So this is the important aspects of examination, but I think you guys probably would cover this quite well, because the examination of a burn is very similar to an examination of any limb. You want to see that there's no underlying injuries. The most commonest injuries that are associated with burns are... Amy?
Would you think like dehydration?
What's an underlying injury? Think of crush and burn.
Oh, like a soft tissue injury or a fracture.
Fracture. Commonest injuries are fractures and burns. That's entirely correct. So full range of motion is important. Why is Capri fill important? Shannon?
Because you want to kind of ensure that the blood supply to the distal part of the limb is still perfusing.
That's it. And it's painful everywhere. As you've characterized it, it looks like a combination of both, maybe partial thickness, maybe full thickness, but you know it's extensive burn in that left hand. So analgesia. Analgesia is really important. We do it really badly. What would you do? What would you guys do? So you ran it underwater for about 20 minutes. You got a little bit of pain relief, but when you took it out, it's still painful. Who hasn't yet said anything?
I don't know probably what I'd give, but I know that you said like whether they have pain or pain free isn't really an accurate descriptor of like the thickness of their burns. I don't know, I'd probably give them analgesia as soon as possible, so then hopefully after that 20 minutes something's kicked in so you can examine them.
That's yeah.
But I don't know what to give, but
yeah. What if you had to remember your most basic of analgesia management? So where would you start? What's
like your Panadol and your anti-inflammatories.
Yeah, that's
and then
perfect.
Work your way up, like
That's
non-opioids, I guess opioids sort of thing.
Perfect.
How bad it is and like the age of comorbidity, stuff like that.
Yeah, that's brilliant. So start with your ladder. So start with your paracetamol, your Brufen, buy yourself some time. Maybe give some oxycodone. And burns are painful. We do this really badly. I just want to make sure this is something that everyone understands in burns management. It's the number one predictor. In any study that you see, if whatever your outcome is, the number one predictor of how well they do, when they'll go back to work, PTSD and mental health issues, wound healing, somehow it's incredible. But analgesia is the number one predictor of improvement in all these areas. So you want to make sure that you manage someone's pain appropriately and you manage it well. So that's exactly what I did in ED. So paracetamol, Brufen, about 5 to 10 of oxycodone in a naive patient, IV cannula on the other side, morphine running through. So morphine, not fentanyl. Any thoughts? Why fentanyl? Why morphine? This is a bit...
I guess the pain would be quite long lasting, so you would have to keep redosing the fentanyl, so it's a bit shorter acting.
That's it. That's it. That's perfect. Yeah. So you want to give something, give it a couple of times, not every 30 minutes, or really sometimes with fentanyl, you just have to keep on dosing every 10 minutes or so to get a good effect. Whereas with morphine, you'll have about 2 to 3 hours of pain relief. And how I did it, so the other side, so one side, right hand, there was a cannula, morphine running through. Other side, would you consider a local? So in this case, and I don't expect you guys to know this, but I did all 4 blocks, median nerve block, ulnar nerve block, radial nerve block, and a digit block, so a ring block right there in that middle finger, because I thought that would need a bit more debridement. So that's what ended up happening. He was quite, he had a vasovagal, but he was pain-free. So what comes next? So his pain, we examined him, we took a good history, you've given good analgesia. What comes first? I kind of just said it a minute ago. What do you want to do with that blister that you saw? What do you want to do with all those little bits of skin that are about to fall off?
Clean and debride the wound a little bit.
Yep. So you want to debride that wound. So first comes debridement. So that's what it looked like after the first debridement. So it was very satisfying. Debriding a wound correctly is impossible to teach unless you've actually done it. You've seen someone do it. You've seen a video. You could see a video, but really you actually don't know what you're doing until you're actually doing it. So the most basic is that you grab onto the skin, you use scissors to cut the blister, you lift, and you really just cut around that skin to get nice edges there. But that's the most basic of debridement. You don't want to lift and pull clean skin and good skin. You want to just cut around where the burn ends, really, and debride it and make it quite clean. Well, what's wrong with this one here? What does that look like? What's the problem with this one particularly? Not the nail, just under the nail. What happens when burns heal over time, well, actually, what happens in the first 24 to 48 hours of burns? So do you remember that area of vasodilation? Fluid shifts out, you get edema in that site. What does that look like here? Has anyone heard of circumferential burns? Yeah? No? Some people say no, some people say it. So circumferential burns is a burn that goes all the way around, whatever limit is. So you can refer to circumferential burns. Truncal burns can be circumferential. Digit burns can be circumferential. They're quite common to be circumferential. Anywhere around the body where the burn goes all the way around is a circumferential burn. And the problem with those is when fluid shifts out, there's edema at the site. Fascia does not, even in arms and legs, fascia does not stretch. Muscle stretches, right? There's not much fascia in that finger there, really. So there's no fascia at all. So that would just shift out, and then you get something similar to what you get somewhere else when fascia doesn't stretch and muscle stretches. That's called?
That's a compartment.
That's it, compartment syndrome. So that can happen distally as well, and that can cause necrosis at the distal edge of that finger. So you want to make sure that you manage that appropriately. And I'll tell you guys how. So management. Here's some ideas. So someone already mentioned that tetanus injection. And I'm just going to tell you what dressing. And it's the stock standard dressing. It doesn't change. It's the same dressing for every single burn. So if you've seen that Intrasite before, this is where it's used most commonly. Intrasite, Acticoat. And Acticoat's kind of the silver that they have to activate with water for irrigation, not with normal saline. So water for irrigation only, because then it breaks down with normal saline. And nurses know how to do this. So the next time you're in ED and someone's actually doing this, make sure to watch how they're doing it, because it's a very good skill to have. But then you're just coming down to the crux of it, because you told someone, you've debrided the wound, you've given really good analgesia, he's pain-free, and he tells you, how often should I be getting these dressings changed? Any thoughts? Daily dressings, second daily dressings, weekly dressings? Take a guess.
Do you start off with quite frequent, like daily, and then slowly space it out?
That's a good idea. But there's actual research that there's really no room, there's no evidence for daily dressings in burns. It's a really good idea, but there's no evidence at all. So you want to do second daily or third daily dressings, particularly in burns, because it minimizes the amount of trauma that's applied to the area. What about prophylactic antibiotics? Any evidence for that, you guys reckon? I see John going, yep. The surgeon right there.
There is evidence for it.
Actually, no, there isn't. Nope. But you did say the tetanus injection, so brownie points. What about analgesia to take home? Morgan, you mentioned the latter, so I would do that as well. So you do that and a bit of oxy to take home. Yep. So good analgesia. Home with education. So signs of compartment syndrome, wound evolution, infection. So what I mean by wound evolution, so just like we talked about, wounds are dynamic in nature. They're going to change after a while. I've seen a wound that looks very, very clean on day 1. On day 3, it looked like a melted black candle. It looked like a partial thickness burn when it first came in. And then it looked like a full thickness burn 2 days later. And I had to go up the road, had to get debrided, had a staph infection. So it's really important to make sure that the patient understand that you're not falsely reassuring them. You're not telling them it's a full thickness. You're not telling them it's a partial thickness. You're saying to them, look, this is a pretty bad burn. We don't really know what it is. It looks like this to me. I don't know how it's going to heal, but if you want it to heal well, you should probably cut down smoking. You should probably keep up with your wound dressings. So come back in about 2 days to get it reevaluated. So regular reevaluation of the burn is really important because it evolves over time. And for that finger that you guys just saw, just there, where is it? Just there. So what you do is, so you cover that with dressing just at the end, and then you keep the tip of that finger visible, and the patient squeezes it every once in a while. Make sure there's cap refill under 2 seconds, and make sure that sensation is quite intact and it's not turning black or blue. So that's what you do for that finger there, to make sure that there's no compartment syndrome or it doesn't evolve to become that, particularly in the first 72 hours. When should you see them again? Just like I said, so 2 to 3 days, they should see their GP. This guy was from Bunbury, so he went up to Bunbury and saw, I went to ED there. And anything else you can think of. I do this for all my wounds. There's something else. This is kind of like asking you to be a mind reader. It's a bit of a...
I don't know if it's what you're thinking of, but maybe like work, when they can return to work.
That's a good one.
People and help them out with stuff.
Yep. So
Is it to not get it wet?
Yep, that's a good one. Yep. So don't get it wet. That's good advice. Work, medical certificate. Yep. Anything else? We're really being holistic here. So you're quite good. You've just done everything. You've managed this guy down to the T. And wound diary. Wound diary is great because the only person that can have a wound diary that's sufficient in this setting is the patient. So take a photo of the wound every time it gets dressed and undressed, which is why I get to show you what it looks like. So 2 days later, it looks like this. See how different it looks? That part of that wound needs to be redebrided. All that skin's lifted off. So the area of the wound, the area of the burn is much more extensive than we first thought. We thought it was a lot more. This is what it looks like first when we debrided it. So have a quick look there, and that skin around it, it's just lifted off and needed to be redebrided in the second instance. There as well, that needs to be redebrided again. Post-secondary debridement, I did not do that one. I don't know who did that one, but not too bad. So second debridement, 2 weeks in. Looks like that. Looks pretty good. 3 weeks in. Dynamic, changes over time. So you can tell 7 to 14 days later, this is more likely a partial thickness burn. This is healed. It didn't become charred, it didn't become black. It lifted off, but it really didn't. So that was pretty good. Now, that's what it looks like. So it's pretty good. It doesn't have that stricture that you can get with burns because they get quite tight after a while. So that's really good burns management. Yes, in the first instance, it was great, and I'd like to say I did a pretty good job, but it's not me. It's every single wound dressing after me that was pretty good. So he was pretty on top of it. So that's simple wound management, simple burns management. Was that helpful? I hope it was. I hope you get to debride something when it comes to ED next, because people are quite clumsy in Albany. But any questions about burn management? I'm just going to go back to this because I'm proud of it. This guy never had any infections. He never had any problem with healing. He never had any problem with compartment syndrome. So it's a pretty good outcome.
I guess, Tammy, I have a question. If you had like a small area of burn on like a torso or something, how would you run that underwater in ED?
Oof.
Would you?
Yeah, that's a good one. So I wouldn't run that. Well, ideally, if you have someone who's come in and there's a truncal burn, they've really jumped in the shower. Ideally, they've jumped in the shower for 10 to 20 minutes. They come to ED, it's going to be a little bit difficult, but you do have pretty nice loved ones who will just literally run water over the patient until they put them into the shower in ED. So you can do something.
Yeah.
We do have a shower there, so they can jump in there.
Okay, cool.
You should get a hose in ED.
Thank you, John. I'll let them know. Any other questions? It's going to be tough to numb if it's on the torso, but local probably do it best. That's what I do there for truncal burns. It's usually a local anesthetic. But usually you see limb limb burns much more commonly because people touch hot stuff and do stupid stuff with their hands, like this guy. Cool, I think that's about it. Thanks guys for sitting on my burns talk. Next time there's a burn in ED, please jump in and debride. Cool.
Awesome. Thanks, Tammy.
Thank you
No
so
worries.
much.
Pleasure.
Tammy.
No worries. See you guys. Have a good night.
Yeah, no, no.
Bye.
Bye, Alex.